All right, welcome back to the deep dive. Today, we're going to tackle some pretty fascinating fractures. We're going around the shoulder girdle, focusing on the scapula, coracoid, and the acromion.
Sounds good.
And this deep dive is really tailored specifically for all of you orthopedic residents out there who are, gearing up for those big postgraduate exit exams, the FRCS or the equivalent.
All right.
So, we're basing this session on the Ortho Made Simple notes from mokyingren.sg.
Yeah.
And these notes are put together by Dr. Mok Ying Ren, who's a sports surgeon at National University Hospital in Singapore. And, he did his FRCS back in 2022. So, he's been through it. So, you've probably, you've seen these fracture patterns in your rotations and, really understanding, all the little nuances and the management. It's really key, not only for great patient care, but also for those exams.
Absolutely. These are high yield topics for those exams.
Yeah.
Okay, so let's just dive right in. Let's start with scapula fractures. When you're faced with a question on classifying these, what system should just immediately pop into your head, and why is that system so important?
So the classification that comes to mind is the Eidberg classification. And the reason why this is important is it's all structured around the glenoid involvement.
Okay.
So it's the articular surface, and that's the money. That's the most important part of the scapula.
Right.
So understanding which part of the glenoid is fractured and how that fracture line extends really gives us a clue about potential instability and how that affects the function.
Okay. So walk us through the different Eidberg types and what makes each one, sort of distinct when we're talking about, how much of that glenoid is involved.
Okay, so starting from type 1, type 1 involves a fracture of the glenoid rim itself.
Mm-hmm.
So this can be either an anterior or posterior chip fracture. Then moving on to type 2, it's a fracture of the inferior glenoid rim.
Mm-hmm.
And this is often associated with shoulder dislocations.
Right.
Type 3 runs from the superior glenoid rim all the way to the base of the coracoid process.
Ah, okay.
So that really disrupts that superior suspensory complex.
Okay.
Type 4 is a horizontal fracture line going through the neck of the scapula
Okay.
and extends medially to the body.
Mm.
And finally, type 5 is like a combination of the two. So you have a horizontal neck fracture with a partial articular fracture of the glenoid.
Okay. Yeah, that really paints a picture of, the whole spectrum of how bad that glenoid can be messed up. So, when we think about managing scapular fractures, like what's the general rule? Like what do we usually do?
So for the majority of scapular fractures, non-operative management is the way to go. And the scapula actually has a remarkable capacity to heal.
Yeah, and there's some pretty good evidence to support that, right?
Yes, there was a systematic review published in 2006 in the Journal of Orthopaedic Trauma,
Mm-hmm.
and they looked at isolated scapular body fractures. And they found that a striking 99% were treated non-operatively,
Wow.
and 86% of those had acceptable results.
Wow.
So that really speaks volumes to the inherent stability that a lot of these fractures have.
Yeah. Wow, 99%. That's a big number. So, okay, so if non-op is usually what we do, when do we start thinking, okay, maybe we should fix this? Like what are some of the criteria that would push us towards, taking somebody to the operating room for a scapula fracture?
So there are a few key factors that come into play here.
Yeah.
One of the critical measures that we look at is a glenopolar angle. So that's GPA.
Okay.
If that angle is less than 22 degrees, that's a strong indication for us to consider surgery.
Okay, and the glenopolar angle, that's basically telling us, how much inferior tilt there is of that glenoid, right?
Exactly. So the glenoid, you can think of it like a shallow cup.
Yeah.
And when the GPA is less than 22 degrees, that means that the cup is tilted downwards too much.
Right.
And that can make it difficult for the humeral head to sit securely.
Yeah. Okay. And just to kind of refresh everybody's memory, like what lines are we actually, using to form that glenopolar angle?
So there are two lines. One connecting the most superior and inferior points of the glenoid fossa.
Okay.
And then the other line is connecting the most superior point of the glenoid with the most inferior tip of the scapular body.
Okay. Got it. So, a smaller angle means, that glenoid is just, really tilted out of its normal position. Okay. So GPA below 22, what else are we looking for?
Another key indicator is the degree of medialization,
Okay.
which we quantify using the lateral border offset,
Mm-hmm.
or LFO. So if the lateral border of the scapula is displaced medially by more than 25 millimeters,
Okay.
that's a lot. That suggests a significant shift in the scapular anatomy.
Right. Right. And then, a big angulation, in that AP plane, more than 45 degrees, that can also be a problem, right?
Yeah.
Potentially leading to impingement against the rib cage. Okay, and then we also talked about, the floating shoulder.
Yes.
So in the setting of floating shoulder, if there's a fracture that involves the glenoid and there's a good amount of displacement, that's usually going to need to be fixed, right?
That's right, because the entire superior shoulder suspensory complex is compromised.
Yeah, yeah. Okay, so we've kind of identified the situations where we might need to operate. So if we do decide to go to the operating room for a scapula fracture, what's the typical approach that we're going to use?
So the posterior judate approach is our workhorse for addressing most fractures of the scapular body and glenoid.
Okay.
And it provides us with excellent visualization of the posterior aspect of the scapula, which is where a lot of the key fracture lines are located.
Okay, and what are some of the key anatomical landmarks, the nerves, the vessels that we really need to be mindful of, when we're doing this approach?
There are a few key neurovascular structures that are at risk. In the suprascapular notch, you have the suprascapular nerve.
Mm-hmm.
And as you dissect more distally, we need to be very careful around the quadrangular space,
Yeah.
where the axillary nerve and posterior circumflex artery travels.
Okay.
Yeah. Those are definitely areas where you want to be very meticulous with your dissection.
Yeah, for sure. So what position is our patient typically going to be in for this judate approach?
Typically, the patient is positioned in the lateral decubitus position,
Okay,
so lying on their side.
got it. And then just briefly, what's our incision going to look like, and what are those first couple steps of the dissection?
So the incision typically follows the line of the scapular spine, and it curves inferiorly and medially towards the inferior angle. The initial dissection involves carefully exposing and releasing the deltoid muscle from its origin along the scapular spine.
Right.
Once that's done, you'll identify the infraspinatus muscle superiorly and the teres minor inferiorly.
Okay.
And we then retract the teres minor inferiorly, which helps us to visualize the structures within the quadrangular and triangular space.
Okay.
And that allows us to reach the posterior aspect of the joint capsule.
Got it. Okay, so that's a good overview of scapular fractures. Let's move on to the coracoid. Is there a classification system that we should be familiar with for coracoid fractures?
Yes, the main classification for coracoid fractures is the Ogawa classification.
Okay.
Yeah.
And what are the different types in that Ogawa system?
So type 1 fractures occur behind the coracoclavicular ligaments at the base of the coracoid.
Okay.
And these are very interesting because they have a strong association with floating shoulder injuries.
Really?
Yeah, about 94% of the time. So that highlights the high energy nature of these fractures.
Right. Okay.
And then type 2 fractures are located anterior to the coracoclavicular ligaments.
Okay.
So typically they involve the tip of the coracoid.
Got it. So yeah, that's really interesting that, that type 1 that almost always has a floating shoulder.
Yeah.
Really kind of shows you how connected everything is up there.
Yes, exactly.
Okay. So let's switch gears and talk about fractures of the acromion. What about a classification system for acromial fractures?
So for acromion fractures, we use the Kuhn's classification.
Kuhn's, okay. And
Yeah.
how does Kuhn's break these down?
So Kuhn's has 3 main types, with type 1 having 2 subtypes.
Yep.
So starting with type 1A, it's an avulsion fracture, often involving the deltoid origin or the trapezius insertion.
Okay.
Type 1B is a non-displaced true fracture of the acromion.
Okay.
Then moving on to type 2, it's a displaced fracture where the subacromial space remains relatively normal.
Oh.
And by subacromial space, we mean the space between the acromion and the rotator cuff.
Right.
And then finally, type 3 is also a displaced fracture. But the key here is there is a reduction of the subacromial space.
Okay, so that reduction in the subacromial space, that seems like a pretty significant finding. How does that typically happen? What are the mechanics that lead to that reduced space?
So there are 2 ways that this can happen.
Like,
Either you have superior displacement of a glenoid fracture,
okay.
which essentially pushes the humeral head and the rotator cuff upwards toward the acromion.
Right.
or you have an inferior displacement of the acromion fracture itself.
Got it. Got it. Okay. So basically, understanding how that injury happened,
Yeah.
and if there are any other fractures, that's really going to help us figure out, what type of acromion fracture we're dealing with. Okay. So when do we typically operate on an acromion fracture?
So the primary surgical indications are Kuhn's type 3 fractures,
Okay.
where the subacromial space is compromised,
Right.
and any acromion fracture with a significant displacement of more than 1 centimeter.
Okay.
Yeah.
Yeah. So that displacement can also, cause problems, mechanically and with pain. And if we do need to fix an acromion fracture, like what are some of the common ways that we're gonna do that?
So a reversed distal clavicle plate is often a good option for fixation. Because of its shape and the screw configuration, it often lends itself very well to stabilizing these types of acromion fractures.
Okay. Okay. So we've looked at the individual scapula, the coracoid, and the acromion. But now let's really kind of take a deep dive into this whole concept of the floating shoulder,
Okay.
which we've touched on, a couple of times now. But can you first just clearly define, like, what makes up the superior shoulder suspensory complex, or SSSC?
So the SSSC is a very important ring of bony and soft tissue structures that provide stability to the shoulder girdle.
Right.
And it's made up of 4 bony elements: the coracoid process, the acromion, the clavicle, and the glenoid.
Okay.
And these are all interconnected by 2 key ligaments: the coracoclavicular ligaments and the acromioclavicular ligaments.
Got it. Got it. So it's really like this, load sharing ring
Yes.
that kind of keeps everything, where it's supposed to be.
Keeps the shoulder attached to the axial skeleton.
Yeah, exactly. Exactly. Okay, so with that in mind, like how do we define a floating shoulder injury?
So the classic definition, which is attributed to Ganz and Nosberger back in 1975,
Okay.
it describes this as an ipsilateral fracture of the mid-shaft of the clavicle,
Okay.
combined with a fracture of the neck of the glenoid.
Got it. So essentially, that glenoid is just kind of floating out there.
Yes,
Yeah.
exactly. It's no longer attached because you've
Yeah.
disrupted the 2 main bony attachments.
Right, the clavicle and then the scapula itself.
Yes.
Yeah. Okay. So how do we manage these? What's the current thinking on how to treat a floating shoulder?
So the management of floating shoulder injuries, it remains a bit controversial.
Okay.
But a systematic review published in 2020 in the Journal of Shoulder and Elbow Surgery by Dombrowski and his colleagues suggested that, satisfactory outcomes can be achieved with both operative and non-operative treatment.
Okay.
But they really emphasized that the approach needs to be tailored to the individual patient.
Right, right. So it's not, one size fits all.
Absolutely not.
Yeah.
Yeah.
Yeah. It really depends on the the specific patient and the exact injury pattern. Are there any kind of specific things about a floating shoulder injury that would make you say, okay, this definitely needs an operation?
Yes. So particularly injuries with significant displacement of the scapular neck fracture,
Okay.
which often correlates with a large reduction in the glenopolar angle that we talked about earlier.
Right.
If that's not addressed surgically, you can have poor functional outcomes
Yeah.
because that glenoid alignment is not restored.
Okay. Okay. And if we do need to operate, do we always have to fix both the clavicle and the scapula, or can we get away with just fixing one or the other?
So that's a good question. And there was another systematic review
Mm.
by Moray and colleagues
Mm-hmm.
that looked specifically at this. So they compared non-operative treatment,
Mm-hmm.
fixation of only the clavicle,
Okay.
and fixation of both the clavicle and the scapular neck.
Okay.
And what they found was that there wasn't a significant difference in overall outcomes between these surgical strategies.
Wow.
Yeah. And in some cases, they were even similar to non-operative management.
Wow.
So that really reinforces the idea that it's not so much about fixing every fracture.
Right.
It's about restoring that glenopolar angle
Okay.
and the overall glenoid stability.
Got it. Got it. Yeah. So it really all comes back to that glenoid and making sure that SSC is intact. Well, this has been great. This deep dive into fractures around the shoulder girdle based on those ortho-made simple notes from mokyingren.sg. It's really clear that non-operative management is a big part of what we do.
Yeah.
But we really have to understand, those classification systems
Yeah.
and when we need to operate.
Yeah, absolutely.
It's really important not just for taking care of patients,
Right.
but also for doing well in those exams. And it seems like, we're still learning about these injuries. These are tough injuries. We really got to think about, the biomechanics and how everything works up there.
These are challenging injuries, that's for sure.
Yeah, yeah. So here's something, for everybody to kind of chew on as you continue to study these injuries. And this is also based on, those ortho-made simple notes from mokyingren.sg,
Hmm.
thinking about all the complex biomechanics of that superior shoulder suspensory complex. How might different injury patterns within that complex, affect somebody's shoulder function long term?
It's a good question.
Yeah.
That's something to really think about.
Yeah, and that's regardless of how we treat it initially.
Right.
Are there certain injuries, that are just going to do worse no matter what we do. That's something to really think about. Well, thanks for joining us on this deep dive,
My pleasure.
and we'll see you next time.
See you next time.
All right.
Bye-bye.